One of these values is going to stop this heart in the next 10 minutes, and the other 3, the ones that look far louder, are every one of them safer. 40 questions. Everyone hands you a critical value and asks what you do first, and the reflex answer is usually the wrong one. Not because the content is obscure, but because the number that looks scariest is rarely the one that kills. By the end, a value will not frighten you. It will tell you exactly what to do. Is it critical? Is it changing? What does my action do? Let's begin. Before the values, one idea that changes everything. Most reviews teach lab values as a list of numbers to memorize. That is not what the exam is testing. It is testing whether you know what the number means for the patient in front of you. So, here is the thesis. For the next 40 questions, a lab value in a STEM is never scenery. It is never there for decoration. If the question hands you a potassium, the potassium is the reason, and it is the hinge the whole answer turns on. A critical value is a medical emergency, not a data point. Recognizing it is only half the answer. The exam wants the other half, the action. See the value, and your next thought should already be the first thing you do about it. But not every abnormal-looking number is a crisis, and not every scary number needs a call. This is where strong students lose points. You have to know the normal range is cold, so a value that is actually normal can never masquerade as an emergency. Trend beats the single number. 4 values sitting inside the normal range but marching the wrong way will hurt your patient before dramatic value that is holding still. Read the direction before one dramatic value that is holding still. A lab value plus a symptom or a change on the ECG is no longer a lab value. It is an emergency, and it jumps the line. A potassium with peaked T waves is a rhythm problem now. Airway, breathing, circulation, ahead of every quieter finding. 5 families carry most of the high-yield items. The electrolytes that stop the heart, glucose and the diabetic emergencies, the renal and acid-base panel, the blood counts and coagulation labs, and the therapeutic drug levels. Learn these 5 and you own the exam. Sometimes the right value points to the right drug, but the trap is the route or the timing. Potassium is never pushed. Insulin waits for fluids in ketoacidosis. The correct action at the wrong moment, or by the wrong route, is still a fatal error. Memorize the antidotes as pairs, because the exam swaps them on purpose. Warfarin is reversed by vitamin K, heparin by protamine, magnesium toxicity by calcium gluconate, digoxin by digoxin immune fab. When you see the poison, name its antidote before you read on. The single most tested pharmacology trap. Heparin is monitored by the aPTT. Warfarin is monitored by the INR. Mix that pair up, and you will misdose the anticoagulant and miss the item. Heparin with aPTT, warfarin with INR. So for every one of the 40, ask 3 questions in this order. Is this value critical? Is it changing? And what does my action actually do to this patient? Every one of the 40 items has its own timestamp in the description, labeled by value and topic. Jump to the lab you keep missing. Now, question 1. First family, the electrolytes that stop the heart. Potassium, sodium, calcium, magnesium. These are the values that turn into a rhythm emergency the fastest. And the reflex answer is often the one that arrests the heart. A client's potassium returns at 6.8 milliequivalents per liter, and the monitor shows tall, peaked T waves with a widening QRS. What does the nurse do first? Peak T waves with a widening QRS mean the myocardium is already destabilizing toward a lethal rhythm. Calcium gluconate does not lower the potassium, but it protects the heart in seconds, while the slower shifting and removal steps are set up. So, the answer is D. Insulin with dextrose is the reflex pick because it actually lowers the number, but it takes 20 to 30 minutes to work, and the heart cannot wait that long once the QRS is widening. Shift the potassium after you have stabilized the membrane, not before. Sodium polystyrene sulfonate removes potassium over hours. Far too slow for ECG changes. Repeating the level wastes the minutes the peaked T waves are warning you about. Hyperkalemia plus ECG changes is a rhythm emergency. Calcium gluconate buys the time that insulin needs. A client with a potassium of 2.8 milliequivalents per liter is prescribed potassium chloride replacement. The client is on a cardiac monitor with a patent IV. What does the nurse do first? Potassium is never given IV push. Potassium of concentrated potassium stops the heart. It must fund salt attack. A pulsal of askybe of 10 rungel. Presents in 10 milliequivalents pastop potassium in the face. It must be diluted and infused on a pump, no faster than 10 milliequivalents per hour peripherally, with the client on the monitor the whole time. So the answer is A. Pushing it slowly feels safe because the client is monitored, but there is no safe IV push rate for potassium. The peak concentration at the heart is what kills, and dilution is the only thing that prevents it. Slow push is still a fatal order. Holding a dangerously low potassium leaves an arrhythmia risk untreated. Oral bananas cannot correct a level of 2.8 fast enough and do not replace the ordered IV route. IV potassium is always diluted and pumped, never pushed. The route, not the dose, is the trap here. A client in acute kidney injury has a potassium of 6.9 milliequivalents per liter with peaked T waves. Build the bow tie for the first phase of care. Every listed action could be a real order in some context, so this is pure sequence. Calcium gluconate to protect the heart, then insulin with dextrose to drive potassium into cells. Watch the rhythm and recheck the level to prove the treatment worked. Those are the two first actions, and the two parameters to watch. Adding potassium or a potassium-sparing diuretic is the trap. Both raise potassium, the exact opposite of the goal. Yet they look like plausible potassium orders to a rushed reader. A 24-hour urine protein and a lipase have nothing to do with an unstable rhythm and waste the minutes the ECG changes are counting down. When every option sounds like a potassium order, eliminate the two that raise it, then sequence the rest. Nurse reviews 4 electrolyte results. Classify each by how urgently it must be acted on. Not every out-of-range value is the emergency. The potassium of 6.7 with peaked T waves is the only lethal now finding. It is an active rhythm threat. A sodium of 133 and a magnesium of 1.2 are mildly low and worth a call, but not emergent. A calcium of 9.6 is squarely normal. That is how each value is classified. Calcium of 9.6 is the trap. Students see a decimal near a limit and reflexively report it, but 9.0 to 10.5 is the normal range, so it needs nothing. Chasing a normal value steals attention from the potassium that is about to arrest the heart. A mildly low sodium and a diuretic-related low magnesium are report and replace, not immediate life threats in an asymptomatic client. Know the normal ranges. Cold. So a normal value can't masquerade as a crisis. The number needs a symptom to become an emergency. Exam Pearl. A lab value in a STEM is never scenery. If they took the trouble to hand you the number, the number is the hinge the answer turns on. A client with a sodium of 118 milliequivalents per liter has a witnessed tonic-clonic seizure. The client is now postictal with a patent airway. What does the nurse anticipate first? A sodium of 118 that has already caused a seizure is symptomatic. Severe hyponatremia with cerebral edema. Only hypertonic 3% saline raises the sodium fast enough to pull water out of brain cells and stop the seizures carefully to avoid overcorrection. So the answer is B. Fluid restriction is the correct treatment for mild chronic dilutional hyponatremia. So it feels right. 비미호흡, right. But restricting fluid works over days, and this brain is swelling now. Matching the mild case reflex to a seizing client lets the cerebral edema win. An isotonic bolus barely moves a sodium of 118 and adds free water relative to need. Seizure precautions are supportive but do nothing to correct the underlying sodium. The same low sodium is treated opposite ways by severity. A seizure means severe. Reach for 3% saline. The client is 6 hours post-total thyroidectomy. Calcium is 7.2 milligrams per deciliter. Select all findings the nurse must act on. At a calcium of 7.2, the neuromuscular system is hyperexcitable. Perioral tingling and a positive Trousseau sign, carpopedal spasm with the cuff, are early tetany. An inspiratory stridor signals laryngospasm, an airway emergency after thyroid surgery. All three demand action. The correct selections light up now. The correct selections light up now. A blood pressure of 128/76 with a heart rate of 78 is normal and is the distractor. Post-op vitals invite a reflexive. Watch it, but there is nothing to act on. A dry throat and a request for water are expected and unrelated to the calcium. Totally amarns but totally. I voice readly about more 25th, but the blubbelated Grinwan healths so show are made it. We can functure and maybe besina fritriscoli. I know have shikit will do. Reclassities are atressibly. For anything evoluted beflacis. Keep calcium gluconate at the bedside after thyroidectomy, precisely because stridor can appear suddenly. The airway sign outranks every other cue here. After a thyroidectomy, low calcium is an airway story. Chivostek, Trousseau, and stridor are the cues that move you. A laboring client on a magnesium sulfate infusion for preeclampsia becomes lethargic with absent deep tendon reflexes and a respiratory rate of 9. What does the nurse do first? Absent reflexes with a respiratory rate of 9 is magnesium toxicity heading toward respiratory arrest. The very first move is to stop the infusion so no more magnesium enters. Then give calcium gluconate, the antidote, and support breathing. So the answer is D. Continuing the antidepensive follows the preeclampsia frame. Sanripravici, up of myself waste fariumph. The reason the drip was started, but that frame no longer governs. Once toxicity appears, the magnesium itself is the threat, and treating the blood pressure ignores the failing respirations. Merely slowing the rate keeps toxic magnesium infusing. Extra fluids help excretion far too slowly for a respiratory rate of 9. Absent deep tendon reflexes and a falling respiratory rate on magnesium means stop the drip and reach for calcium gluconate. A client is post-op day 1 after major surgery with new oliguria. The nurse reviews the potassium trend and the monitor. O600, K 4.9 milliequivalents per liter. Urine 40 milliliters per hour. ECG normal. 1000, K 5.5 milliequivalents per liter. Urine 24 milliliters per hour. T waves peaking 1400 K 6.1 milliequivalents per liter. Urine 14 milliliters per hour. QRS widening 1800 K 6.8 milliequivalents per liter. Urine 7 milliliters per hour. Heart rate 48. Trajectory is unmistakable. Potassium climbing 4.9 to 6.8 as urine output collapses, with the ECG marching from peak T waves to a widening QRS and bradycardia. This is the failing kidney, driving lethal hyperkalemia. Escalate and ready the calcium gluconate. So, the answer is A. Continue to monitor. Each value is only mildly high, is the exact trap. No single step looks alarming. So the reflex is to keep watching. Waiting for one number to look catastrophic means waiting for the arrest. The widening QRS is already predicting. A low potassium diet cannot touch a level of 6.8 with ECG changes. Documenting it as expected misreads a clear climb toward arrest. Read the arrow, not the number. Potassium climbing while urine falls is a rhythm emergency building in slow motion. The trend beats the single number. 4 in-range values moving the wrong way will outrank one scary value that is holding still. Read the arrow. Glucose and the diabetic emergencies. Low sugar, ketoacidosis, and the hyperosmolar state. The same high glucose is treated in completely different orders, and the missing detail decides which. A client on insulin reports feeling shaky and diaphoretic. The fingerstick glucose is 45 milligrams per deciliter. The client is alert and able to swallow. What does the nurse do first? An alert client who can swallow gets 15 grams of fast carbohydrate, niachamely or tune plaf tablets, and about the emplaced impossibility emily or tune glos, energeta contused a carbohydrate, depla by glucose cardrate, juice or glucose tablets, then a recheck in 15 minutes. It is the fastest safe correction and it matches the client's ability to protect the airway. So, the answer is C. IV dextrose 50 works, and it is the reflex when the word hypoglycemia appears, but it is reserved for the client who cannot safely swallow. Using an invasive route on an alert, swallowing client is choosing the wrong tool for this patient. Glucagon is for the unconscious client without IV access. Giving more insulin to a glucose of 45 would deepen the very emergency you are treating. Match the hypoglycemia route to the airway. Can swallow, give carbs by mouth, can't, go IV or intramuscular. A client with diabetes is found unresponsive and diaphoretic. The glucose reads 38 milligrams per deciliter. There is no intravenous access in place. What does the nurse do first? An unresponsive client cannot protect the airway, so nothing goes in the mouth. With no IV yet, intramuscular glucagon is the correct route. It raises glucose without aspiration risk, while a line is being started for dextrose. So the answer is B. Oral glucose gel feels like a fast fix and is right for a drowsy but awake client. But in an unresponsive client, the cheek and gums still lead to the airway. The intuitive oral route here causes aspiration, not recovery. Orange juice in an unresponsive client is a clear aspiration hazard. Withholding all treatment lets the brain starve. While you wait for access, glucagon does not require. Unresponsive and hypoglycemic with no IV means glucagon. Never put food or gel in a mouth that can't swallow. A client presents in diabetic ketoacidosis. Glucose 548 milligrams per deciliter, pH 7.16, potassium 5.4 milliequivalents per liter, and marked dehydration. Place the first hour actions in order. Fluids come first because the client is volume depleted and insulin without volume drops an already empty tank. Confirm potassium next. Insulin drives it into cells, so a low value must be replaced before you start insulin. Then insulin, then dextrose near 200, then hourly rechecks. That is the correct order. The tempting first step is to start insulin, because insulin is what fixes the ketoacidosis. But insulin before fluids and before checking potassium can crash the blood pressure and the potassium at the same time. Right drug, wrong moment. Adding dextrose too early keeps the glucose high. Skipping the hourly rechecks blinds you to the potassium fall insulin is causing. In DKA, the order is fluids, potassium, then insulin. Insulin is never the first thing you hang. A client being treated for DKA now has a glucose of 232 milligrams per deciliter, down from 548. The insulin infusion is running, and the anion gap is still elevated. What does the nurse do first? Glucose of 232 looks reassuring, but the still open anion gap means the ketoacidosis is not resolved. Insulin must keep running to close the gap. You add dextrose to the fluids so it can continue safely without dropping the glucose too low. So the answer is C. Stopping insulin, because the sugar is normal now, is the classic trap. The glucose corrects long before the acidosis does. Turn insulin off with an open gap, and the client slides right back into ketoacidosis. A snack does not close an anion gap and interrupts the controlled infusion. Slowing the fluids misreads a near-normal glucose as the endpoint, when the acid-base picture is the real target. In DKA, you keep insulin running until the gap closes, adding dextrose as the glucose falls. A normal sugar is not the finish line. A normal glucose is not the finish line in ketoacidosis. Treat the anion gap. The sugar corrects long before the acid does, so the insulin keeps running. Or clients present with altered glucose. Match each Q cluster to the condition it points to. The right condition changes the priority action. Cool, clammy, and tremulous at 44. Is hypochromia, is hypoglycemia. Treat the sugar now. Fruity breath with small respirations and ketones is DKA. Both remaining rows, glucose 810 and 690, profoundly dehydrated with no ketones, are HHS, and the missing ketones are what make the call. That is how each value is classified. The buried Q is ketones present versus absent. Students lump every high glucose into DKA, but HHS has profound dehydration without ketosis, and it is treated with aggressive fluids first. Miss the missing ketones and you misjudge the whole priority. Fruity breath and small respirations are unique to the ketotic DKA picture. The hypoglycemic client is the only one you feed rather than hydrate or give insulin. Not every high sugar is DKA. The presence of ketones is the buried Q that sorts DKA from HHS. An older adult arrives confused with a glucose of 815 milligrams per deciliter, no ketones, and dry mucous membranes with poor skin turgor, hyperosmolar hyperpricemic state. What is the first priority? HHS is above all a fluid deficit emergency. These clients are often many liters dry. Restoring circulating volume comes first. Rehydration alone lowers the glucose substantially and protects perfusion before insulin is added. So the answer is D. Leading with high-rate insulin follows the DKA frame, where insulin is central, but in HHS, Insulin before adequate fluids pulls water and glucose into cells and can collapse an already depleted intravascular space. The two hypersemic frameworks diverge exactly here. There is no significant acidosis in HHS, so bicarbonate is not indicated. Fluid restriction is the opposite of what a profoundly dehydrated client needs. HHS is a water problem before a sugar problem. Fluids first. Insulin follows the volume. Renal and acid-base panel. Creatinine, the blood gas, lactate, and ammonia. Here you interpret the number and then act on what it says about perfusion, the kidney, and the acid in the blood. Client in acute kidney injury on a fluid restriction has several findings this hour. Which does the nurse report to the provider first? Potassium of 6.5 with peaked T waves is symptomatic hyperkalemia. The membrane is already destabilizing toward ventricular fibrillation. An ECG change turns a lab value into an immediate cardiac emergency that jumps ahead of everything else. So the answer is A. Low urine output is the reflex pick in kidney injury and is genuinely concerning, but oliguria over 1 hour will not kill in the next few minutes. The hyperkalemia with ECG changes will. Reporting the output first delays the rhythm threat. A blood pressure of 156/94 is common in kidney injury and not emergent. Fatigue and poor appetite are nonspecific uremic symptoms. A lab value plus an ECG change is no longer a lab value. It is a rhythm emergency that jumps the line. Client with type 2 diabetes on metformin has a creatinine that rose from 1.0 to 2.3 milligrams per deciliter and is scheduled for a contrast-enhanced CT scan this afternoon. What does the nurse do first? The buried Q is the creatinine climbing to 2.3-G. Kidney function is dropping. Metformin plus iodinated contrast in a failing kidney risks lactic acidosis and contrast nephropathy. So the nurse holds the metformin and questions the contrast before harm is done. So the answer is A. Giving the metformin to control glucose treats the number the nurse is used to watching and misses the one that matters here. In a rising creatinine, metformin is the drug you hold, not the one you protect. Sending the client to contrast without addressing the creatinine bakes in the nephrotoxic hit, simply charting the trend and moving on. Lets a preventable injury proceed. Creatinine is the kidney's honest number. When it climbs, hold the nephrotoxins before the next insult lands. Creatinine is the kidney's honest number. Hydration does not fake it. When it climbs, hold the nephrotoxins before the next dose lands. A client with COPD has an ABG pH 7.28, PaCO 268 mm of mercury, HCO 326 milliequivalents per liter, PaO 258 mm of mercury. Select all correct interpretations and priority actions. A low pH with a high PaCO2 is respiratory acidosis. The CO2 is the acid the failing lungs cannot clear. The airway and ventilation come first, and the PaO2 of 58 is true hypoxemia needing controlled oxygen. Targeting the COPD client's lower saturation goal. The correct selections light up now. Calling it metabolic alkalosis inverts the Rome rule. pH and CO2 moving in opposite directions is respiratory, and a low pH is acidosis, not alkalosis. The bicarbonate here is near normal, confirming the problem is respiratory. Coaching rapid deep breathing assumes a client who can blow off CO2, but a tiring COPD client is retaining it. The fix is improved ventilation and airway clearance, not forced hyperventilation. Read the gas with Rome. CO2 up and pH down is respiratory acidosis, and the lungs are the priority. A client is being watched for kidney injury after a hypotensive surgery. The nurse reviews the trend across 4 days. Day 1, creatinine 1.0, urine 55 milliliters per hour, blood pressure 124/78. Day 2, creatinine 1.6, urine 36 milliliters per hour, blood pressure 120/76. Day 3, creatinine 2.4, urine 20 milliliters per hour, blood pressure 118/74. Day 4, creatinine 3.2, urine 11 milliliters per hour, blood pressure 116/72. Blood pressure looks fine every day, which is exactly the distraction. Creatinine tripling from 1.0 to 3.2 while urine output falls is acute kidney injury in progress. Hold the nephrotoxic drugs and notify the provider before the next dose lands on a failing kidney. So the answer is A. Continue to monitor, Continue to monitor, The blood pressure is stable anchors on the one value that looks okay. A normal pressure does not undo a creatine climbing off a cliff. Waiting for the blood pressure to change means missing the kidney injury that is already here. Pushing protein raises the nitrogen load on a failing kidney. Calling a tripling creatinine expected recovery misreads a clear downhill trend. Watch the value that is moving, not the one holding still. A rising creatinine with falling urine is AKI, whatever the blood pressure does. A client meets sepsis criteria. Temperature 39.1 degrees Celsius. Heart rate 122. Blood pressure 88/52 and a lactate of 4.6 millimoles per liter. Place the first hour sepsis bundle actions in order. Every step is correct. This is sequence. Cultures are drawn before antibiotics, so the antibiotic does not sterilize the sample. The lactate quantifies hypoperfusion, then antibiotics within the hour, then the fluid bolus for the low pressure, then a repeat lactate to judge the response. That is the correct order. Giving antibiotics first feels most urgent because sepsis kills. But antibiotics before cultures cost you the organism and the sensitivities. The 1-minute delay to draw cultures protects the only sample that guides definitive therapy. Fluids and the repeat lactate are essential, but they follow cultures and antibiotics in the bundle, rather than leading it. Draw cultures before the first antibiotic. One right action in the wrong order costs the whole workup. Kurzikingsate before you're repeating senatep kurj the coat uter. At the talkiosk of a quartet if it's professional from an antibesti. Follow Dino. Before the antiallergies that even about like destiny for follow ante. Big anticlassic biotics protecting the lactate first. I know, one in the foregon a real changed. But costs a chuck. A calm on my work. Client with cirrhosis becomes increasingly confused and disoriented. The ammonia level is 168 micrograms per deciliter. And asterixis is present. What does the nurse anticipate first? Rising ammonia with new confusion and asterixis is hepatic encephalopathy. Lactulose is the priority. It acidifies the gut and pulls ammonia into the stool, targeting 2 to 3 soft stools a day. It treats the actual cause of the altered mentation. So, the answer is B. Sedating the agitated client with lorazepam is the dangerous reflex. Benzodiazepines are cleared by the failing liver, deepen encephalopathy, and can mask a worsening neuroexam. The confusion here is metabolic, not behavioral. Total protein elimination is outdated and worsens malnutrition. Modest protein with lactulose is preferred. A head CT chases a less likely cause, while the treatable ammonia climbs. Confusion plus a high ammonia in liver disease means lactulose, not a sedative. Never quiet a metabolic delirium with a benzodiazepine. A lab value plus a symptom, or plus an ECG change, is a different animal. The change, not the number, sets the priority. Blood counts and bleeding, hemoglobin, platelets, and the white count. The trap is crossing the wires. Low platelets bleed, low white cells get infected, and the precautions are not the same. A client, 2 days post-op, has a hemoglobin of 6.6 grams per deciliter, a heart rate of 118, and reports dizziness when sitting up. 2 units of packed red cells are ordered. What does the nurse do first? Hemoglobin of 6.6, that is symptomatic, tachycardia and orthostatic dizziness, is below the transfusion threshold, and the client is already showing the effect. Verifying consent and the blood bank match, and starting the transfusion is the priority. It treats the oxygen-carrying deficit. So the answer is B. Waiting for the dizziness to pass sounds cautious, but the dizziness is the anemia. It will not resolve without the red cells. Delaying treats a symptom by withholding the fix, letting the deficit deepen. Oral iron raises hemoglobin over weeks, useless for symptomatic anemia now. Documenting the value while withholding ordered blood ignores an active oxygen delivery problem. A hemoglobin under 7 with symptoms is a transfusion, not a recheck. Symptoms mean the deficit is already costing the patient. Client receiving chemotherapy has a platelet count of 18,000 per cubic millimeter. Which set of precautions does the nurse implement first? Platelet count of 18,000 is below the spontaneous bleeding floor of 20,000. The priority is bleeding precautions. Soft toothbrush, electric razor, no intramuscular injections, no aspirin or NSAIDs, and fall prevention to avoid a bleed. There is no clotting reserve to stop. So the answer is A. Neutropenic precautions are the mix-up trap. Both belong to chemotherapy clients. But neutropenic precautions track a low white count and infection risk. This is a low platelet count, so the danger is bleeding, and the precaution set is different. Contact precautions address transmissible organisms, not this count. Calling 18,000 not yet critical ignores that it sits under the spontaneous-bleed threshold. Low platelets, bleeding precautions. Low white count, neutropenic precautions. Don't cross the wires. A neutropenic client with an absolute neutrophil count of 380 per cubic millimeter spikes a new temperature of 38.6 degrees Celsius. What does the nurse do first? An ANC of 380 with a new fever is neutropenic fever, a medical emergency, because a client with almost no neutrophils can be septic with no other signs. Cultures then broad-spectrum antibiotics within the hour is the time-critical bundle that saves lives. So the answer is D. Reaching for acetaminophen treats the number on the thermometer and erases the single warning a neutropenic client can mount. Masking the fever while the infection runs unchecked is the right comfort action at exactly the wrong time. Documenting and rounding or waiting for morning labs. Both burn the hour in which antibiotics must reach a client who cannot fight infection alone. Fever in neutropenia is an emergency clock. Cultures and antibiotics within the hour don't just treat the temperature. Client has a platelet count of 24,000 per cubic millimeter. Select all interventions the nurse includes in the plan of care. At 24,000 platelets, the plan is bleeding prevention, a soft toothbrush and electric razor to protect gums and skin, withholding aspirin, NSAIDs, and intramuscular injections that provoke bleeding, and prolonged pressure to any puncture site because the clot has little reserve to form. The correct selections light up now. Strict protective isolation is the distractor pulled from the neutropenic playbook. It guards against infection, not bleeding, and does not belong to an isolated low platelet count. A routine enema is contraindicated. Rectal trauma in a thrombocytopenic client can cause serious bleeding, so it is avoided, not scheduled. With low platelets, everything that could nick a vessel is off the table. Protect skin, gums, and mucosa. Low platelets bleed. Low white cells get infected. Never cross the two precaution sets, because the same chemotherapy client can need either one. The nurse reviews 4 blood counts on a chemotherapy unit. Classify how urgently each must be handled. One near normal value hides the real emergency. Two findings are emergent: platelets of 16,000 that are already bleeding, and an ANC of 360 with a fever, which is neutropenic sepsis until proven otherwise. A hemoglobin of 11.2 with mild fatigue is worth reporting but not emergent. That is how each value is classified. The WBC of 9,200 is the buried normal. It sits inside the 5,000 to 10,000 range, so it needs nothing. Yet a nervous reader may report any lab on a cancer unit. Reacting to the normal value steals time from the two that are truly emergent. A hemoglobin of 11.2 warrants follow-up and trending, but does not compete with active bleeding or neutropenic fever for immediacy. Know the normal white count, so it can't distract you. The emergencies are the bleeding platelets and the febrile neutropenic client. 15 minutes into a packed red cell transfusion, the client develops fever, chills, flank pain, and dark urine. Place the nurse's actions in the correct order. These signs are an acute hemolytic reaction, the most dangerous transfusion emergency. Stop the blood first, so not 1 more milliliter of incompatible cells enters. Keep the line open with saline on new tubing. Notify, reassess, and re-verify identification. Then return the bag and a sample. That is the correct order. Instinct is to notify the provider first, but seconds of continued incompatible blood worsen the hemolysis. Stopping the transfusion is the action that stops the harm. The phone call comes right after, not before. Re-verifying identification and returning the bag are essential for the workup, but follow stopping the blood and protecting the vein. Any transfusion reaction? Stop the blood, run saline on new tubing, then notify. The first move is to stop the harm. Coagulation and the anticoagulants, the INR, the aPTT, heparin, warfarin, and the clot that the drug itself can cause. Pair each drug with its lab and its antidote, and don't get them backwards. A client on warfarin has an INR of 8.2 and no signs of bleeding. The provider is called. What does the nurse anticipate as the priority intervention? An INR of 8.2 without bleeding is dangerously over range but not yet hemorrhaging. Holding the warfarin and giving vitamin K, its antidote, lets the INR drift down safely without the overcorrection that aggressive reversal would cause. So the answer is A. Protamine sulfate is the reversal reflex, but it reverses heparin, not warfarin, a classic pairing trap. Giving it here does nothing for a warfarin INR, and delays the vitamin K that actually works. Platelets do not affect the INR, which reflects clotting factors, not platelet count. Continuing warfarin at 8.2 keeps pushing the INR higher toward a spontaneous bleed. Warfarin high and not bleeding means hold it and give vitamin K. Protamine belongs to heparin, not warfarin. A client on warfarin has an INR of 8.5 and is now vomiting bright red blood. What does the nurse anticipate first? Active hemorrhage with an INR of 8.5 needs immediate reversal, not gradual correction. Prothrombin complex concentrate, or fresh frozen plasma, replaces clotting factors right now. An IV vitamin K sustains the reversal. Speed is the whole point once the client is bleeding. So the answer is B. Merely holding the dose and rechecking tomorrow is correct for a high INR that is not bleeding, and that is the trap. The moment active bleeding appears, waiting for the drug to wear off is far too slow. You must replace factors now. Oral vitamin K alone is too slow for a hemorrhage. Applying pressure to the mouth does nothing for an internal upper GI bleed and delays definitive reversal. Same high INR, opposite tempo. Not bleeding, hold and vitamin K. Bleeding, reverse immediately with PCC or plasma. Heparin pairs with the aPTT, warfarin with the INR. Their antidotes cross the same way. Protamine for heparin, vitamin K for warfarin. A client is started on a continuous IV heparin infusion for a pulmonary embolism. Which laboratory value does the nurse monitor to titrate the drip? Heparin is monitored by the aPTT, kept at roughly 1.5 to 2.5 times the control. The aPTT reflects the intrinsic pathway heparin acts on, so it is the value that guides every rate change on the drip. So the answer is D. Choosing the INR is the #1 anticoagulant pairing trap. The INR belongs to warfarin. Heparin and warfarin look interchangeable to a rushed reader, but each has its own lab, and titrating heparin by the INR would leave the client misdosed. The PT tracks warfarin's pathway, not heparin's. A bedside bleeding time is not used to titrate a heparin infusion. Heparin goes with a PTT, warfarin goes with INR. Mixing the pair is the most tested farm trap on the exam. A client on IV heparin for 6 days has a platelet count that fell from 265,000 to 88,000 per cubic millimeter, with a new clot in the leg. What does the nurse do first? A platelet drop of more than half on day 6 of heparin with a new clot is heparin-induced thrombocytopenia. The immune reaction both consumes platelets and drives clotting, so the priority is to stop all heparin, including flushes, before the next clot forms. So the answer is D. Transfusing platelets seems logical because the count is low, but in HIT the problem is clotting, not bleeding. Added platelets feed the thrombosis. The low number is a red herring that points the wrong way. Continuing or redosing heparin because there is a clot is exactly backwards. Classic effused malt. The heparin is causing the clots here and must be removed, not increased. Platelets falling on heparin with a new clot is HIT. Stop all heparin. Stop clot. Don't transfuse platelets into a clotting storm. A client is being discharged on warfarin. Select all statements that require further teaching before discharge. Two statements are unsafe and need correction. Adding a daily aspirin stacks bleeding risk on top of the warfarin, and doubling a missed dose spikes the INR toward hemorrhage. Both reveal a dangerous misunderstanding of how warfarin is taken. The correct selections light up now. Keeping leafy green intake about the same is actually correct. The warfarin teaching is consistent vitamin K, not avoidance. So selecting it as needing teaching is the negative stem trap. Steady greens keep the INR stable. The soft toothbrush and report black stool statement and keeping scheduled INR draws are both correct. Safe behaviors. Only the aspirin and double dosing statements are wrong. On warfarin, keep vitamin K steady, never double a dose, and avoid added aspirin. Read the negative stem twice. Client on warfarin arrives with an INR of 9 and active gastrointestinal bleeding. Build the bow tie for immediate management. With active bleeding, the two first actions are to hold the warfarin and reverse it. Now, with IV vitamin K plus prothrombin complex concentrate. Then, trend the INR to confirm reversal, and follow the hemoglobin and vital signs to gauge blood loss. Those are the two first actions, and the two parameters to watch. Protamine sulfate is the decoy. It reverses heparin, not warfarin. So it looks like a reversal agent, but does nothing here. Giving another warfarin dose during a hemorrhage is the opposite of the goal. The aPTT tracks heparin, not warfarin, and an ammonia level is irrelevant to this bleed. Neither guides the reversal. Warfarin bleed, hold it, reverse with vitamin K and factors, and watch the INR and hemoglobin. Protamine is heparin's antidote, not warfarin's. Not bleeding versus bleeding changes the tempo, not the drug. Hold and reverse slowly when there is no bleed. Replace the factors now when there is. The therapeutic drug levels: digoxin, lithium, phenytoin, and vancomycin. A number inside the range can still be a hold, and a number just over the line can already be toxic. Read the level and the patient. Client on digoxin has a level of 2.6 nanograms per milliliter, a heart rate of 46, nausea, and reports seeing yellow-green halos. What does the nurse do first? A level of 2.6 with bradycardia, nausea, and visual halos is digoxin toxicity. The nurse holds the drug at once and checks the potassium, because a low potassium potentiates digoxin and would keep the client toxic even after the dose is held. Severe cases need digoxin immune fab, so the answer is C. Giving the next dose, because it is scheduled, pours more drug onto a toxic level. And a heart rate of 46? I'm phenytoin, my cartoon reel. Keeps your classic more UGC best of more cart dose. Let's do a cartoon could be the emergencies. So or plastid 46. Your classic 40 can weave. More first post energy the silly giggles. Your classic of 43. The reflex to stay on schedule is exactly what worsens the toxicity. Emelic. An antiemetic treats the nausea as if it were a stomach problem, masking a toxicity sign. Encouraging fluids and waiting until morning leaves the bradycardia untreated. Digoxin toxicity means hold the drug and check the potassium. A low potassium keeps the heart toxic even after you stop dosing. A client on long-term lithium presents with a level of 2.1 milliequivalents per liter, coarse tremor, ataxia, and vomiting after a week of poor fluid intake. What does the nurse do first? A level of 2.1 is over the toxic threshold, and tremor, ataxia, and vomiting confirm toxicity. The nurse holds the lithium and gives isotonic fluids to restore volume and promote excretion. Severe toxicity may need dialysis. Dehydration and low sodium both drive lithium higher. So the answer is C. Calling 2.1 barely high and dosing anyway is the trap of the value that looks almost normal. But lithium's therapeutic window ends at 2.0, and the symptoms prove this client is already toxic. A decimal over the line still means stop. Fluid restriction concentrates lithium and worsens toxicity. A low-sodium diet raises lithium levels. Since the kidney reabsorbs lithium when sodium is low, lithium's ceiling is 2.0, and low sodium or dehydration pushes it higher. A number just over the line with symptoms is toxic. A client is ordered IV phenytoin for status epilepticus prophylaxis. Place the nurse's administration steps in the correct order. Phenytoin precipitates in dextrose, so the very first check is that the line is normal saline, then the inline filter, then a slow rate, no faster than 50 mg per minute to avoid cardiac collapse, with rhythm and pressure watched throughout, and a saline flush to clear the line. That is the correct order. Jumping straight to starting the infusion is the trap. If the line still has dextrose hanging, the phenytoin crystallizes and can embolize. Verifying the saline compatibility must come before the drug ever runs. The filter, the slow rate, the monitoring, and the flush are all correct, but each depends on first confirming a saline line. Phenytoin runs only in saline, filtered, and slow. Check the fluid before the drug. Dextrose precipitates it. The nurse reviews 4 therapeutic drug levels. Classify each. One value that reads inside its range is being given to the wrong patient state. Lithium 2.4 and phenytoin 26 are both frankly toxic and held. The vancomycin trough of 12 is therapeutic. The digoxin of 1.1 is in range, but the heart rate of 52 is below the hold parameter. You hold digoxin for a pulse under 60, regardless of a normal level. That is how each value is classified. The digoxin is the buried case. A level inside the therapeutic window tempts you to give it, yet the bradycardia is the finding that governs. A normal drug level does not override a clinical hold parameter. The lithium and phenytoin numbers exceed their toxic thresholds with matching symptoms, and the vancomycin trough sits squarely in its therapeutic band. Read the level and the patient. Digoxin holds for a pulse under 60, even when the number looks fine. Read the level and the patient. A therapeutic digoxin still gets held for a pulse under 60. The hold parameter beats the number. 20 minutes into an IV vancomycin infusion, a client develops flushing of the face and neck, itching, and a mild drop in blood pressure. What does the nurse do first? Flushing, itching, and mild hypotension early in a vancomycin infusion is the infusion rate reaction, red man syndrome, caused by giving it too fast, not a true allergy. Slowing the rate and giving an antihistamine treats it, and the drug can usually be continued more slowly. So the answer is A. Labeling it a true allergy and stopping vancomycin forever is the framework error. An allergy is immunologic, but this is a rate-related histamine release. Mislabeling it removes a needed antibiotic from the client's future for no reason. Continuing at the same rate lets the reaction worsen. Speeding the infusion up drives more histamine release and deepens the hypotension. Vancomycin flushing is a speed problem, not an allergy. Slow it down and don't retire the drug. Gauntlet. The 3 hardest. No scaffolding. Everything you just learned, mixed together, with the critical value hiding among the normal ones. A nurse receives morning labs on 4 clients. Select all values that require stat provider notification. Four cross the stat line. A potassium of 6.6, arrhythmia risk above the critical ceiling. A pH of 7.18 with a bicarbonate of 12, severe metabolic acidosis. A sodium of 118 with new drowsiness, severe symptomatic hyponatremia. and a glucose of 38 with confusion, critical hypoglycemia. Each is a recognized critical value. The correct selections light up now. The creatinine of 1.1 is the buried in-range distractor. It is a normal kidney value. On a screen full of numbers, the reflex is to flag everything. But reporting a normal dilutes the 4 that are genuinely lethal. Knowing the stat thresholds cold, potassium above 6.5, pH below 7.2, sodium below 120, glucose below 50, is what lets the nurse pick the critical ones from the noise. On a wall of labs, the 4 that breach a critical threshold are the call. A normal value on the same screen is not. A client with cirrhosis has an albumin of 2.4 grams per deciliter, ammonia rising from 90 to 140 micrograms per deciliter, a subtle flap of the hands, and a normal blood pressure and temperature. What does the nurse address first? Among mostly reassuring findings, the rising ammonia, paired with a new asterixis, is early hepatic encephalopathy, but your follow on the value for gimmitst atish and ammonially or hyperquation Rome is early hepatic encephalopathy, a change in a value that carries neurologic risk. It is the finding that governs, and it points toward lactulose and a careful neurowatch. So, the answer is C. The low albumin is chronic in cirrhosis and tempting to fix with an infusion, but it is a slow, baseline problem, not the acute change. Chasing the albumin lets the climbing ammonia and the developing encephalopathy advance unwatched. The normal blood pressure and temperature are exactly that, normal, and are only distractions from the one value that is moving. In a wall of stable numbers, the one that is climbing with a new symptom wins. Rising ammonia plus asterixis is encephalopathy. Know the stat. Thresholds cold. So a normal value on a busy screen can never hide the one emergency that actually needs the call. A client with cirrhosis and known esophageal varices vomits a large amount of bright red blood. Blood pressure 92/58. Heart rate 118, hemoglobin 7.0. Select all priority nursing actions. Active variceal bleeding with a blood pressure of 92/58 and a hemoglobin of 7.0 is hemorrhagic shock. The priorities are large bore access with fluid resuscitation, airway protection against aspirating blood, and readying octreotide and blood products to control the bleed and replace volume. The correct selections light up now. Giving the routine oral beta blocker is the trap. It lowers heart rate and blood pressure, the exact opposite of what a client in shock needs, and it is oral in someone actively vomiting blood. A scheduled med is not a priority during a hemorrhage. Withholding care to repeat, the hemoglobin freezes the nurse during active bleeding. The shock is already evident and must be treated now, not remeasured first. In a variceal bleed, treat the shock. Access, fluids, airway, octreotide. Don't give a rate-lowering pill to a bleeding patient. 40 values. 40 times a number that looked routine was the whole answer, and a scarier one beside it was a decoy. If you remember nothing else, remember this. A critical value with a symptom or an ECG change jumps the line. A trend beats a single reading. And the same value can be treated in opposite ways, depending on how severe it is. The timestamps for all 40 are in the description. Jump to the value you keep missing and tell me in the comments. Which number did you get wrong? Drop it below and I will explain it further.